Hello, I'm Tudor Jovin. I'm the immediate past chair of the ISC Programming Committee, and it's my pleasure to be here with Michael Hill and Mayank Goyal, both from University of Calgary in Alberta, Canada, who are the co-PIs of the ESCAPE-MeVO trial. First of all, congratulations for carrying out this very challenging trial. Please um, outline the trial and its results for us.
Start? Sure. Thanks, Tudor. Thanks for inviting us. Well, we did a trial of patients who had stroke due to medium vessel occlusion, which we defined as in the M2 segment or distal, A2 segment or distal, and P2 segment or distal. So we had a broader group of patients. They were all treated with routine care, which included slightly more than 50% got routine thrombolysis, and then they were randomized to have endovascular thrombectomy or to control. The overall result is entirely neutral. The proportion of patients who, pretty even on the modified Rankin scale score all the way across the scale, and we did not see substantive safety effects. For example, we did see a slightly more subarachnoid hemorrhage in the intervention arm, but this was not associated with, a more disability. We did see overall very slight trend towards some more serious adverse events in the intervention group, but it didn't appear to be the major contributor here in terms of looking for an effect size that we were hoping to see.
Now, diagnosing an ACA occlusion or a PCA occlusion is a bit less challenging than M2 or distal. Did you include any M2s, or did you only include dominant M2, non-dominant M2s, or how did you deal with the M2s? And do you think that there was some selection bias with regards to M2s due to equipoise issues?
We really don't have the data on the patients that did not participate in the trial, so answering that question precisely is difficult. At the same time, based on conversations, we do think that most centers did not have equipoise for a dominant M2. So we feel like the majority of the patients that were included in the trial were non-dominant M2s and M3s. Now, obviously, as you know, precise definitions of M2, M3, depending on how you do it, is also variable, especially in the heat of the moment when you're trying to do all these things together. So there's expected to be some degree of difference from that perspective. There's also the issue of size of the vessel, where precise measurement of size on CT angiogram is just not possible, given the size of the voxel, which is usually sort of pixel, which is 0.6 millimeters. So, at best you can say 1.2 or 1.8 or 2.4 millimeters. So that is a limitation as well. And obviously, your available information at the point of randomization is the CT angio, not the conventional angio. So we are not able to precisely answer your question, but I do think dominant M2s were probably not included.
And you think the loss of equipoise was based on perhaps size of the vessel, the sheer size of the vessel, or severity of the neurological deficit?
I suspect it's a combination of both, but at the same time, again, the absence of data prevents us to precisely answer the question that we don't have the data on the patients who were not randomized. Another way to think about it is that if you have an exceedingly low enrolling center who has a high thrombectomy volume, then why is it low enrolling? And then you can hypothesize based on that are they in some way, shape, or form cherry picking, or are they low enrolling because they don't have the infrastructure, or are they low enrolling because consent at that center is difficult? But these are all hypotheses. We are not able to precisely answer those questions.
So what do you think explains the negative results? Obviously, when you designed the trial, you expected a positive result. As you mentioned, that a common odds ratio of 1.2, so 20% higher, improved outcomes by 20%. Why do you think that this trial ended up being negative?
Well, one possibility is the trials are right. We had 3 trials presented today, which one incomplete, stopped early, but all showing similar results, which suggests that in the populations we chose to treat, there is not a dominant treatment effect. But in that, like all trials, that's the average effect of all the people in the trial. So probably some patients did a little better and some patients did a little worse. Picking which of those patients would do better is fundamentally the question you're asking. I'm not sure, Tudor. None of us know exactly for sure, but I make a couple of observations. One is, in trials over the last 10 years, we've been treating older and frailer and sicker patients. And so it's possible that even though we open the artery, the dominance of the underlying status of the patient resulted in the outcomes being similar, right? And we weren't able to show a change. I have to think that that's part of it. There was a very slight increase in the number of adverse events, and we wonder, in an older, sicker population, many more had general anesthesia. We're out in the distal circulation. We cause a little bit more subarachnoid hemorrhage in the few percent range, right? Are those cumulative things enough to then result in diminution of any potential effect size? But these are all speculative things. And the other side is that maybe medical treatment's pretty good, right, for this population.
Yeah, and speaking of medical treatment, I noticed, and correct me if I'm wrong, I haven't read the paper. I just saw on the slides that you showed. There was no treatment effect modification by lytics, right?
That's correct.
And so that was a bit surprising to me. That even in patients who did not qualify for lytics, there was no signals of benefit.
I'll just say one thing. We did look at the group. So in the group that got randomized to intervention, who did get thrombolytic, and then we had a subsequent angiogram, right? So we had a CT angiogram showing a MEVO. They got lytic, and then we had a subsequent first view angiogram. In a large majority of those patients, I think it's about 85% or 90%, the occlusion was still there. So it isn't true to say that the explanation for the difference here is that we recanalized all those patients with lytic.
Yeah. So just drawing the analogy to 2013, right? The reason why 2 years later we had positive trials after negative trials, in my opinion, was overwhelmingly due to technological advances. We can quibble about everything else, but at the end, probably what made the big difference was just the ability to open these vessels in an effective way with stent retrievers at that time. Is this a similar moment, you think, that the devices are not good enough? Do we need to design better devices, or maybe use lytics, or is the approach fundamentally not good?
Yeah, so we were talking about this earlier, this exact question. So if I go back to 2013, I think it was Hawaii that we were all there. So at least at that time, based on my recollection from 12 years ago, there was obviously the part about stent retrievers and better opening of the vessel. The other part was just being able to see an occlusion, which was not there in a significant number of patients in IMS3. So just diagnosing that there is a large vessel occlusion. And the third thing probably was, obviously we don't have data on it, is that the negative trials reduce the amount of cherry picking in the subsequent trials. But it seemed like the pathway forward was pretty clear when we designed the ESCAPE trial, and you were involved with REVASCAT, and we all had discussions at that time. Correspondingly, it is not completely clear to us that hypothetically, if I had X amount of resources and Y amount of centers and stuff, and people said, okay, let's start the trial again, it's not clear to me what would be the steps the way that it was clear to me in 2013. And I do think we'll probably have to do a Hermes-style meta-analysis, look at the subgroups, look at other factors, and then probably not be in a hurry to jump into the next trial without really thinking it through. Michael?
Yeah, Tudor, I do agree with you that the evolution of the stent retriever technology was essential. And if you remember, in IMS3, the rate of recanalization at the end of the procedure was only 45%. And once we got to 75% and above in ESCAPE and Revascat and Swift Prime and others, we were able to show it. But there were other things as well, which Mayank alluded to. One was imaging. We were much more confident with imaging the parenchyma, and once we got into the other trials, and then the other one was speed. We were slow in IMS3 and MR in synthesis and MR rescue. And that, I remember doing MR rescue. We did MR rescue at our center, and it was just so slow. We were imaging with MRI. It was so, before we actually got to the procedure, the brain was infarcting in front of us. And once we figured out that speed was critical, that was important too. So maybe it's a combination of things. Maybe there's better tech, and as Mike described in his presentation, he developed a scale for MeVO in terms of understanding the reperfusion in the area of that particular artery, and scored it at 75%. It's pretty good. Maybe it needs to be higher with these small end arteries. We've wondered a lot about this concept that once you get out to an M3 or to that kind of thing, are you really dealing with more of an end artery? So collaterals don't matter as much. And if that's true, then you got to be faster. We can't have a 12-hour or 24-hour window. We got to treat people maybe under 3 in the lab. And maybe we need to go as you like. Let's just forget it. Go straight to the lab, right? Forget the CT. I don't know. I'm not sure.
And one thing that I briefly mentioned in the presentation as well is whether modified Rankin is the best scoring system from this perspective, and we've been working on it. So hopefully we should see a publication soon. So we've been working across Canada. So the score is called Cosmos Canadian Outcome Score for minor stroke. And we've taken into account many of the factors that people feel are important for them, such as if someone is a runner and they're not able to run, or someone plays the violin, or someone likes to cook, or someone goes for a job, or someone is a stay-at-home grandmom but is not able to take care of the grandkids. So the way that we've developed the score is taking those into account, and I wonder if that will play a critical role in going forward, especially at the lower end of the stroke scale. So that's why, sort of going back to the point that I think we have to be thoughtful and look at all possible pieces of evidence in terms of jumping forward into the next trial. Like obviously having higher than 75% TQ2B3 would obviously be nicer, and it'll play a role, but that can't be the be all and end all of this story.
But clearly, this, I agree with you, cannot be the be all end all of the story, because in the control group, the outcomes were not that great. I mean, treatment or control groups, right? So just like in distal, it looks like these are not benign strokes. So where next? I mean, one possibility is to develop more in the direction of tools that are specifically designed for these kind of vessels. But another one is pharmacological lysis, whether local or systemic. What are your thoughts on that?
Well, I think it opens it up. We've had the same experience with MeVO here as we did with Tempo 2 last year, which was a trial of tenecteplase versus double antiplatelets in very minor stroke, but with occlusions. And even though we could open the arteries more with tenecteplase, we did not see, improvement in the patient's outcomes. So maybe, the challenge still is with current thrombolytic agents, you still only get about 50% opening of the artery in the first couple hours. So is that enough? Maybe, but probably not. I mean, given our experience from IMS3 and others, and what we saw is that probably we need to get things open. So we will need development to figure out what else we could do. So sure, I think there the now scope maybe greater scope for looking at more medical therapies in this population.
But something that Michael already mentioned, like assuming that there's a Hermes-style meta-analysis, what would be worth looking at is that in the patients in whom the vessel is open and well open, the 2C3 category, how much better is the outcome? And then if those patients, the outcome is not substantially better, then is the base problem is that the selection of patients, we are taking older, sicker patients who are just not going to do that well.
Yeah.
So that's sort of another consideration that we have to keep in mind going forward.
Yeah, it is just possible, as you mentioned, that the threshold for, just like in 2000, after 2013, the threshold for randomization will be very different. It's absolutely possible. But just from a practical standpoint, you know, what should we do with M2 occlusions? You know, I think that the answer with these more distal occlusions right now is pretty clear. You know, you know, individualize, as you said, you have the violin player or the truck driver who needs his vision or whatever, and they understand, you know, you can individualize, but in general, it sounds like this treatment now cannot be endorsed. Um, but um, but what is not that clear, based on what I've seen, is should we all of a sudden reverse all the our practice with regards to M2s? Um, the previous trials have actually shown quite robust benefit in these M2s. So where do we stand with M2 thrombectomy and indication thereof?
Well, I think if it's severe deficit and a biggish M2, then those patients were not really included in these trials.
And how do you define biggish M2?
Yeah, so I don't know, like that's a problem in terms of measurement, in terms of sort of how do we call it kind of thing. But one easy way is it's an M1 looking M2. And obviously each person will define it the same way. I do not think we should be sort of sitting there and in the middle of the night and measuring the M2, which is imprecise anyway.
Yeah.
But I think if and there's the practical side to it. If the NIH is 14, I don't think that practice is going to change. Most people, if it's a biggish M2 with a biggish NIH, they're probably going to go to endovascular thrombectomy. But the other part that is there is that there's also the part about um, um, individual comfort level, local practice, which is going to vary from country to country and probably also center to center. I do think what one doesn't want in a person with NIH 3, 4, 5 is to have a complication and make the situation worse. So I do think there is this being cognizant of that if you do a procedure with relatively mildish NIH, that you do not have a complication. And that is almost like common sense irrespective of the results of the trial. But the other hope is that similar to 2013, that we as a collective can come up with a clear plan. The one other thing that is there is that we designed a sample size of 530 and similar sort of thing as what Distal did. If we do move forward, I do think one should not expect that you'll be able to hit the ball out of the ballpark.
I totally agree with you, but even if you put these two together, I mean, we haven't, the total feeling thing, impression is that if you put these two trials together, you still would not have a positive result.
No, but I'm saying if there is a subgroup from within the two trials that shows a certain amount of effect size, let's say it's 5% as an example, and you would need 2,000 patient trial to show sort of the usual way that we think about things. So I do think we as a collective, irrespective of what happens in the next 4 or 5 months from a trial design perspective, from additional information perspective, have to be prepared for a mega trial.
Yeah, I agree that the days of 300 patients and a positive trial are over.
Yep.
Another thing that came up was interesting, Tudor, at peer review, which we haven't talked about, and it's maybe a bit more delicate, is the expertise of the person doing the procedure. And I think one thing that's happened over 15 years is there's been this there's been a massive influx of people doing endovascular treatment, right? And not all of them are practicing in really high volume centers, have a lot of experience, or are technically really adept at the procedure. And it's possible that that matters, right? That the standardization, I mean, it's a bit like surgical variation, right? So we know this, right? We know this from, say, trauma surgery or cardiac surgery, right? We know that in centers where there's not good standardization or oversight of procedures, that those centers do less well.
I agree. I agree. Yeah, I agree. But then, I mean, you guys, the ESCAPE trials are known for being conducted at centers with very high level of expertise. So if at these centers that level of expertise is an issue, then the treatment is not generalizable. And I think that also answers the question. So, just wrapping this up, how will this affect your practice, the results of this trial moving forward?
Well, I do think in patients with relatively low NIH, and if it's an A2, A3, M3, P3, I think those are pretty clear that they will probably not be considered for endovascular thrombectomy. I do think in patients who are relatively younger, relatively healthier, relatively more severe deficit, and relatively biggish vessel. And then what will end up happening, I suspect, is it'll be a one-on-one conversation between the team, the neurologist, neurointerventionist, as well as patient representative, and being a little bit more frank about, like in a typical M1 occlusion, the conversation is almost like 10 seconds. This is the proximal occlusion. The best thing here is go open the vessel and you sort of move on kind of thing. But here there'll be probably a greater nuanced conversation with the patient family.
So yeah, I do agree. I mean, the lesson that I take home from these trials is if you do it, do it in patients with significant neurological deficit. You can argue about the cutoff, whether it's 6 or 8. And Distal actually did show some trends for treatment effect modification based on NIH. I did not see.
We did a dichotomy though, so we haven't looked at it in that detail. But I agree with you. That makes clinical common sense. That the more severe patients and probably the younger patients, earlier time window, if those things come together, that may be a way to think about the.
And an individual level meta-analysis will obviously
One
shed
thing
a
to
lot more
point out though
light
is
on that.
that when you have a patient with very severe deficit, you just have to be careful. Is it explainable by the MEVO? Because it's possible that it was an M1 occlusion that broke off
Migrated.
and migrated. So just be cognizant of that. And I'm looking at the camera right now that you do have to think about that. Is this MEVO explaining the deficit or not?
Yeah. Well, it's been a pleasure talking to you guys, and the ESCAPE group has been a trailblazer and pioneer in thrombectomy trials, and I'm sure this is not going to be the last big contribution of the group. Congratulations, and looking forward to more trial from you guys.
Thank you very much.
Thanks, Tudor.